indicated in teeth with apical periodontitis, but where there is a persistence of pain, swelling, or unresolved periapical radiolucency and infection, surgical root end resection and retrograde root filling is indicated. So looking into the background, as I mentioned previously, a persistent periapical lesion needs to be addressed firstly by orthograde root treatment, and then further to the failure of that, re-root treatment is indicated prior to considering any surgical intervention. There are some cases, such as rare developmental cysts or tumours, where a surgical approach is indicated sooner. Within the last decade, there have been many advances in endodontic microsurgery, which have been helped particularly by the improvement in instruments and materials that we have available to use in the clinic. Microscopes have improved the visibility and illumination possible during surgery, which has therefore contributed to improved success rates. And materials such as mineral trioxide aggregate are now used routinely, which have superior performance to those previously used, such as amalgam and super EVA. We also have at our disposal CBCT imaging, which has been vital to treatment planning and identification of diagnoses. So quite recently, there was an update to the guidelines from the Royal College of Surgeons into the treatment and management of periordicular surgery. So the ones in the centre of the screen have now superseded the guidelines for surgical endodontics, which were published in 2012. I think it's important to clarify the terminology used throughout this presentation. We're looking at endodontic microsurgery, so it's the use of a variety of materials in adjunct to those, and in most cases more preferably to those used in simple root end surgery. This does differ between departments, and I dare say our practice may be slightly different in Glasgow than it is to other units. But I think it's important to illustrate this throughout the presentation. And as I said, as different departments have variable equipment resources, they may use slightly different techniques. So if we look at the techniques and the differences between the modern apicectomy microsurgery in comparison to the more traditional approach, we can see that, as I said before, CBCT is vital in terms of diagnosis and treatment planning. A high power operating microscope is required, and the type of flap design is also slightly different, with the semilunar flap now falling out of favour in preference for the papilla preservation flap. Speed increasing hand pieces are also required, and the size of the osteotomy is aimed to be kept quite small to minimise post-op complications. Instruments are much smaller, and the actual angle of the root end surgery is perpendicular to the root surface, whereas otherwise it was previously at a bevel. And as I said before, bioceramic cements have now superseded that of amalgam. In terms of closure, monofilament suture is preferred of a small diameter. So this is just a nice visualization of the armamentarium that are used, taken from a paper published in the British Dentistry Journal by Jardin et al. And we can see here on the lower right side of the screen a comparison of how small the microsurgical blade is to the standard size 15, which was previously used in apicectomy. So there are some indications for periordicular surgery, those listed below. So persistent separation from the tooth following a retrograde root treatment. In teeth where there is optimal orthograde root treatment, but still persistent symptoms, or where root canal retreatment has failed, and repetition of the retreatment being detrimental to the structural integrity of the tooth. Also where there are iatrogenic or developmental anomalies that prevent orthograde root treatment, or where biopsy is indicated or perforation or root fracture suspected. Contraindications sort of are listed below, which involve unstable primary disease, a poor coronal seal, that being the crown, if the tooth is unrestorable or there's a combined lesion present, and where the prognosis of the tooth is poor, surgery is not indicated. If there's a vertical root fracture, again, the tooth would be deemed unrestorable and surgery not indicated, or compromise access to the tooth, or any patient factors that may prevent surgery being the optimal preferred method of treatment. So my aim was to review the current available literature on endodontic microsurgery and to look at the outcomes and associated factors compared to that of traditional root end surgery. So there was some, this is my PICO research question. You can see I've obviously outlined the key aims within this. So the sample population of the papers looked at were those obviously that have undergone root end surgery, where sample size was given, where there was at least a 6-month follow-up time to evaluate success and failure, and obviously excluding those where there was a very large lesion, which might require oral surgery intervention as well as restorative, the use of any guided tissue materials, and any combination techniques where microsurgery standards had not been followed. So the methods involved a thorough literature search of the online libraries and analysis of the qualitative themes in each paper. So you can see here a brief flow chart of the data extraction process, categorizing the studies into gold standard, which would obviously be the meta-analysis or randomized control trials, down to the case studies, which weren't graded as high. And in total, 59 studies were evaluated, 3 of which were systematic reviews. So I'm just going to summarize my results of that. So the key topics identified were imaging techniques, sub-factors of operative management, which I'm going to go through now, and also surgical outcomes. So imaging, looking at the literature, in most instances, periapical radiographs were sufficient to facilitate treatment, obviously with a paralleling technique, but a lot of the literature indicated the use of CBCT scans to allow for further aid to treatment planning, especially in tooth where resorption had occurred or there was iatrogenic damage to the root surface. Some considerations also brought up by the literature were that of anatomy. For example, molar teeth being more challenging to treat, and those premolars around the mental foramina being, again, cases where special consideration would be needed with CBCT planning. In a lot of the literature, repeat surgical intervention was significantly less successful than initial surgical intervention, falling below 50%. And in some certain circumstances, coronal management was also indicated. Perforations as well needed to be accommodated for with an additional procedure. Looking at operative management, use of local anesthesia with a vasoconstrictor was indicated to aid hemostasis during the surgery. This was mentioned in a lot of the literature. Whereas there was actually no evidence for routine prophylactic antibiotics in the surgical procedure, apart from in certain circumstances, in which case the patient's medical practitioner should have been contacted. Magnification being key to microsurgery. A series of papers by Setzer et al. 2010 indicated the significant improvement in the success rates using microscopic magnification, And in some studies, simply surgical loops with a high magnification help to improve diagnostic accuracy. In soft tissue management, use of semilunar flaps were mainly contraindicated due to the scarring, where papilla base preservation flaps were more strongly indicated. Obviously, this does depend on the amount of surgical access required. This is just a little video to demonstrate a papilla preservation flap. So you can see the relieving incision there and the microsurgical instrument you use to elevate the flap, keeping the papilla integrity around the 1-1. Here you can see access to the crypt and the infection and separation exuding from that site. So hard tissue management, the literature basically said the larger the crypt, the higher the reduction in success rates. So crypts over 10 millimeters were significantly less successful, with smaller osteotomies reducing healing time for the patient. And again, back exhaust air rotor was preferred to that of surgical slow speed motors. The root end resection itself should be perpendicular, as I mentioned before, with 3 millimeters of the apical region excised. Increased bevels were not indicated due to the greater number of exposed dentinal tubules, and 3 millimeters needed to eliminate any lateral canals and apical ramifications. So the root end filling should be prepared with ultrasonic retro tips, as advocated by von Arx et al. And also looking at use of ultrasonic instruments in preparation to burrs. This is a little video showing an osteotomy and root end resection under microsurgical conditions. So you can see the osteotomy is kept really small, and visualizing the resection of the 3 millimeters of root end and the associated granuloma tissue. That's a microsurgical mirror, so you can see clearly the GP. An ultrasonic tip. Hemostasis being achieved. Just checking for cleansability and drying the root end and placement of MTA in a retrograde to provide a good apical, good seal. So as I said before, previously amalgam and super EBA would be indicated now when we've moved on to bioceramics, and MTA being the preferred gold standard as supported by the systematic reviews. So closure, again, going for reduction of papillar necrosis, small suture sizes with monofilament to minimize any inflammatory action. Again, here is a video showing this. I believe this is a 6.0. We can see here the papilla preservation flap allows ease of approximation of the gingiva, keeping that gingival architecture to allow for aesthetic healing. Management of complications. The literature outlined 3 main complications, being pain, swelling, and post-op of infection as to be expected by any surgical procedure. In general, non-narcotic analgesics were recommended with use of anti-inflammatories to 3 to 5 days post-op, and a cold compress a couple of hours post-surgery, which seemed to benefit most patients. Post-op infection obviously being a potential, mainly reducing this by promoting good oral hygiene post-surgery and antimicrobials if indicated, with a review 24 to 48 hours post-surgery. Briefly looking at the final aspect of surgical outcomes, specifically periapical healing. Rudd et al. Categorized 4 types of healing: complete, incomplete, scar tissue, and unsatisfactory. We can see here that first-time surgery was always better than repeat. A number of papers advocated the use of high magnification, preparation with ultrasonics, and use of MTA. Short-term outcomes, generally the literature reported good quality of life following surgery, patient by patient, with approximately 3 days of pain and swelling following the procedure, with a papilla-based incision reducing post-operative pain. And this was following the meta-analysis, with an 89% healing rate at 12 months reported by Tisas et al. So longer term outcomes, there was a limited literature available here. So 3 particular studies identified. You can see here the sample size and number of teeth are relatively small, as the duration of follow-up is also, but with over 48 months, we've got pretty high periapical healing reported, specifically at 12 months being most high there. So to conclude my talk, although the literature review did highlight rather a lack of large-scale randomized controlled trials, and there was not specific analysis of tooth type, which I think would be beneficial for this talk, we can quite happily follow the guidelines indicated by the Royal College of Surgeons for this movement towards surgical microintervention. Obviously, considering all the factors brought up by the literature to improve success rates, which are reported at generally 79 to as high as 96.8% for this procedure. So those are my references. Thank you very much. I'll take any questions.